It's Tuesday, December 3rd, and this is the Daily Medical News, where we bring you the top headlines in clinical medicine, plus an in-depth look at today's biggest story. I'm Molly Collegio.
And I'm Nick Andrews. Today, physician practices can now apply to join Medicare's direct contracting program.
Why starting antiretroviral therapy at birth benefits infants with HIV.
How the safety profile for the biologic Certolizumab varies by disease.
And what to tell your teen patients who are learning to drive.
Plus, how the Accreditation Council of Graduate Medical Education is rethinking its approach to physician burnout. But first, we'd like to thank all of you who have helped us make this podcast a little better by completing our short listener survey. If you haven't yet and you'd like to provide your feedback, you can take the survey by following the link in the show notes. And now, the top stories in clinical medicine.
Physician practices can now apply to join the Direct Contracting Program, a new payment model aimed at practices serving at least 5,000 Medicare beneficiaries. CMS announced the Advanced Alternative Payment Model in April 2019. The program is for organizations that are ready to take on more financial risk and that have experience managing large populations through accountable care organizations or working with Medicare Advantage plans. The program features two payment options. The professional population-based payment option has a lower risk-sharing arrangement, with practices receiving 50% of any savings and absorbing 50% of any losses. Under the global option, practices receive 100% of any savings and absorb 100% of losses. Letters of intent are due to CMS by December 10th. The agency says submitting a letter of intent won't bind an organization to participating in the program.
And starting antiretroviral therapy within a week after birth rather than waiting a few weeks lowers the reservoir of HIV virus and improves immune response in HIV-infected infants. That's the key finding from the early infant treatment study conducted by researchers at the Harvard T.H. Chan School of Public Health in Boston. They examined the benefits of starting treatment and arresting HIV replication in the first week of life. The researchers screened and treated a group of HIV-infected infants in Botswana within the first week after birth. A second control group started treatment later in the first year of life after being identified as HIV positive at a more standard time of 4 to 6 weeks. The number of reservoir cells was significantly smaller in the HIV-infected infants who started antiretroviral treatment immediately compared with those who began weeks after birth. And immune activation was reduced in the cohort of infants who were treated immediately after birth. The researchers caution that the early intervention isn't curative, but it could set the stage to offer the children more innovative interventions later in life. These data appear in the journal Science Translational Medicine.
Certolizumab risk of serious adverse events varies considerably depending on disease, and patients' disease-related systemic corticosteroid use and obesity have a big impact. A multidisciplinary expert panel convened by Certolizumab's manufacturer analyzed serious adverse events in the TNF inhibitors 49 clinical trials. They presented their findings at the annual Congress of the European Academy of Dermatology and Venereology. The panel's takeaway: when thinking about Certolizumab's serious side effects, think about the condition being treated, whether a patient is on systemic corticosteroids, and whether they're heavy or not. Take, for example, the risk of serious infections requiring treatment with intravenous antibiotics. The incidence rates range from a low of 1.5 per 100 patient years in psoriasis patients on Certolizumab to a high of nearly 6 in those with Crohn's disease. Why the high variability? The explanation lies in part on the huge differences in the concurrent use of systemic corticosteroids with Certolizumab. 3% of psoriasis patients were also on steroids, compared with 46% of rheumatoid arthritis patients and 51% of those with ankylosing spondylitis. Obesity alone wasn't an independent risk factor for serious infection. But the combination of a BMI of 30 or more plus systemic corticosteroid use was linked with a greater risk than with steroids alone. We'll be back after this message with more medical news.
Driving is the most dangerous thing that teenagers do, but physicians and parents can help lower the risks. Dr. Brian Johnston is professor of pediatrics at the University of Washington in Seattle. Speaking at the annual meeting of the American Academy of Pediatrics, Dr. Johnston outlined particularly risky behaviors as well as strategies that can reduce those risks. Inexperience drives the statistics on teen driving deaths. Dr. Johnston notes that crash rates are highest during the first few months after teens begin driving without supervision. Speed is another risk factor, and barely more than half of U.S. high school students say they always wear a seatbelt. Handheld electronic devices such as smartphones are obvious distractions, but a less recognized factor is ADHD, which increases a teen's risk of crashing by 36%. What helps teens most, ironically, is more driving. Dr. Johnston says more time spent driving, with supervision in particular and under diverse conditions, increases the repertoire of skills and abilities. Dr. Johnston says clinicians should consider conducting a driver's physical with new drivers, review medication the teen patient is taking and whether they affect driving, and assess the teen's risks, including any cognitive or other medical conditions that could affect driving safely.
When Dr. Timothy Brigham thinks about the impact of burnout and stress on doctors' ability to practice medicine, Lewin's equation comes to mind. That equation holds that behavior stems from a person's personality and the environment that person inhabits. Dr. Brigham suspects that 70% to 80% of medicine's problem with burnout and stress is environmental. That means trying to reshape personality with resilience training, for example, won't really get to the heart of the problem. Dr. Brigham is Chief Education and Organizational Development Officer at the Accreditation Council for Graduate Medical Education. Speaking at the annual meeting of the American Academy of Pediatrics, he outlined how ACGME is changing its approach to clinicians' well-being and what other steps the community can take. The council launched a call to arms on burnout in 2015, and it's added courses on well-being to its annual meeting and remolded its clinical learning environmental review program to include all clinicians. But Dr. Brigham says ACGME can't requirement its way out of this problem. It's going to take a culture shift, and only doctors, collaborating with their clinician counterparts, can create the systemic change required to improve the culture. Dr. Brigham says clinicians can gauge their risk for burnout by asking themselves 3 questions about their work environment. Does it support self-care? Does it increase and support connection with colleagues? Does it connect people to purpose and meaningful work? He emphasizes that positive social relationships with others are crucial to joy and well-being in medicine. Burnout isn't just about exhaustion, he cautions. It's about loneliness. Dr. Brigham acknowledges that it's a tall task to spotlight well-being when doctors continue to battle prior authorization requirements, clinical documentation requirements, electronic health records, and quality payment programs. Those burdens need to be lightened so doctors can get back in touch with why they became doctors in the first place. And that's it for today's Daily Medical News. Remember, you can find the Daily Medical News on Apple Podcasts, Google Podcasts, Spotify, Pandora, Stitcher, and TuneIn. For MD Edge, I'm Molly Collegio.
And I'm Nick Andrews. Thanks for listening to the Daily Medical News. We'll be back tomorrow.